Just close.
Okay. Okay. Okay, I think we can go ahead and begin. It is 2 o'clock and we're going to go ahead and begin. Good afternoon, everyone. I am Susan Phillips, the president of the Asian Chamber of Texas in Dallas. Welcome to our informational webinar on COVID-19 and the vaccines that are available to us. Understanding the facts and the science is the key in getting this virus under control. And today we are fortunate to have two preeminent doctors to explain the history and current state of the virus, as well as the vaccines that are available to us. Dr. Sudhakar Jonnalagadda is the president of the American Association of Physicians of Indian origin. He currently serves as the gastroenterologist and transplant hepatologist in Douglas, Georgia. Welcome, Dr. Jonnalagadda. Appreciate you being here.
Thank you.
Our second guest speaker is Dr. Sridevi Juvvadi, president of the Texas Indo-American Physicians Association. Dr. Juvvadi completed her pre-medical education at St. Francis Junior College in Hyderabad, India, and received her medical degree from Osmania Medical College in Hyderabad. She currently works as, she completed her residency in internal medicine at St. Barnabas Medical Center in Livingston, New Jersey in 1998, where she was the recipient of Best Resident Award. Congrats, it's awesome. And she is also Best Fellow each year in the Hematology Medical Oncology Division. So she's currently working as an oncologist in the Texas Oncology, pardon me. Dr. Juvvadi was in private practice in Dallas. So welcome, Dr. Juvvadi. And on this note, I'm going to go ahead and turn over the floor to Dr. Jonnalagadda. He's going to start our conversation with some slides. Sir, please take the floor, please.
Thank you, Ms. Susan, for a kind introduction, and also for invitation of Asian Chamber, Texas. Can you share the slide, please? Yeah. Again, thank you for the invitation. I'm sure for the last 1 year, we're going to this dreaded pandemic. And not only United States, the whole globe is suffering with this pandemic going on. Let me start with my first slide of talking about agenda. Can you have next slide, please? We're going to talk about overview of coronavirus and also talk about different kind of coronavirus, 3 of them, and current status of COVID-19 and transmission of the matter, symptoms and prevention and vaccines available at this time. And we'll also talk about how vaccine will work and also the vaccine efficacy, and also very, very important, the variants, which is a major concern at this time globally. And we're going to take some question and answers after that. Next slide, please. You all know that the coronavirus has numerous and are they identified by means of classic spike protein. It first discovered in the poultry in 1930s, and it can cause respiratory symptoms and gastroenterologist symptoms, liver symptoms, and neurological diseases. Apparently, there are only 7 coronaviruses are known to cause human diseases. Out of them, 3 of them are major culprits. So SARS, COVID, which we experienced a long time ago, MERS, Middle East Respiratory Syncytial Virus, and SARS-CoV-2, COVID-19. Can you go to the first slide, please, Ms. Divya? Thank you. If you look at the virion, they call it COVID virion, the virus virion. You see those red, they call spike proteins, which are the way they enter into the human cell. And also it has, it's called, it is a glycoprotein action, it's a glycoprotein. And also has the E protein and membrane protein, all will cause the virulence of this virus. Go back to the third slide, please. Next one. The biggest of SARS outbreak, the severe acute respiratory syndrome, began in China, the first one in 2002. We are not very much affected at that time. About 8,000 cases has been diagnosed. Out of 700 people died in 30 countries. The next one is the Middle East Respiratory Syndrome virus, MERS, identified in 2012. And about 2,500 people died, cases diagnosed, and 850 people have died in 27 countries. The one we are facing right now, the current one, SARS-CoV-2, COVID-19, is the most dreaded one, has been diagnosed so far. It's called a novel coronavirus in 2019 identified. It began in China, Wuhan, and been spread to all over the world, including Antarctica. Dr. Juvvadi is going to mention on that. And also, you can see the different variants has been illustrated on the right side of the slide. Next one, please. Let's take out some data. There are, if you take the United States, entire country, the number of cases being diagnosed about 29 million cases, and over 500,000 people have died. And fatality about 1.8%. In Texas by itself, 2.7 million being diagnosed, out of 46,000 people died. A fatality rate about 1.7%. In Dallas County, about 286,000 people diagnosed with COVID-19 infection. The number of deaths about 3,600. The fatality about 1.3%. The Tarrant County, which probably you all live, 247,000 cases has been diagnosed. Number of deaths about 3,000. So it shows that how severely it infected the human beings, entire globe. Next slide, please. If we take the entire worldwide, 120 million cases has been reported. In the United States itself, about 29 million cases been diagnosed. In the United Kingdom, about 4 million. India, about 11 million. We still don't know why the infection rate is not that in India, the Indian subcontinent. There are several, discussions have happened. Number one, that is people took some BCG vaccination, may give some protection. Some people take the malaria belt. India is a big malaria belt. Chloroquine might have helped them. And also people took some measles and mumps vaccine. There is some sort of protection for them too. Or it could be a natural immunity. It's very difficult to say why it is low, but it's low. But the infection is, infection rate was, there is infection rate, but fatality less than United States and United Kingdom. Next slide, please. the cases in Texas itself, this graph illustrates the beginning of the pandemic in the early of the March and February. This gradually the peak of the infection in the month of July. At the time, you all realized that mask CDC awoke actually at the time and said mask is mandatory. And talking about social distance and hand washing, and pretty much they emphasize the importance. Since then, the case went down, as the graph shows in the month of October. Definitely there is a decline of the case diagnosis in October. And after that, there is some restrictions lifted in month of September. The cases start peaking around. And again, for the month since March, the cases are going down because of vaccination, what we are doing right now in the United States and the globe. Next slide, please. Similarly, the hospitalization also decreased. If you look at the hospitalization in statewide, it's on the brown line, brown graph, color. In Dallas is about blue line. And we see the peak rate has been noticed in the middle of the year. And those, in fact, those admissions were declining after that. Since the February 2021, see the regular decrease in the hospitalization because of COVID-19 virus. I live in a small town, over 60,000, 50, 60,000 population. We're badly infected, hospital full in the middle of the year. And we saw a similar trend that the admissions are decreasing as the days goes on. Next slide, please.
Dr. Jonnalagadda, that was a great summary of magnitude and impact of COVID on the whole universe. As you mentioned, I thought Antarctica was spared, but in December we saw few handful cases. Now that we know how many cases are in the world, United States, UK, can you tell us how it spread from one person to another and what we can do to prevent it?
Good question, Dr. Juvvadi. Well, most important thing, the mode of spread primarily by means of the coughing. Check coughing. There are two kinds of coughing. One is spread by droplets and spread by aerosols. The spread by droplets, because the droplets are heavy size, they can go more than 6 feet. It goes more like than 6 feet. And the droplet size is almost more than 5 micrometers. Another one is aerosols, where the droplet is less than 5 micrometer diameter, and it can go beyond 6 feet. But here is the problem, okay? If somebody exposed to the droplet, which is the social distance less than 6 feet, and without any protection, their infection is going to be pretty severe because this droplet will have more viremia compared to the aerosols. So the mode of spread is pretty much by the aerosols or droplets. Of course, you can carry by means of fomites, touching the surface, contaminated with the virus is also, it can cause the spread of the infection. Close contacts, and pretty much, stay away from touching the face, eyes, and the face. So those are the ways to the infection will spread. And that's the reason why, even though we all get vaccinated, the mask is very important, and social distance is very important, and hand sanitizer is very important until we completely attain the immunity in the United States.
Next slide. Can you tell us what symptoms to watch for, and when should they get physicians' assistance?
Thank you. Good. Next slide, please. I think these are the symptoms usually patient experience. If you look at the influenza, flu virus, this virus also has similar symptoms. They come with headache, fever, and chills, body aches, fatigue, and cough, sore throat, and nausea, vomiting. But most important thing, the first symptom is loss of taste and smell. That's where a lot of patients will experience. Taste and smell is gone. And some people experience shortness of breath and difficulty breathing. And diarrhea. Diarrhea is not that common. About 20% of patients with the COVID-19 infection, they present with diarrhea, like gastrointestinal symptoms. And again, you should look at that, because any diarrhea doesn't mean that you have COVID-19. Okay? This you have to evaluate further and look at all the symptoms patient experience. So these are the one has to features. We should always look into that, and particularly, the smell and taste is very, very important. Next slide, please.
Actually, I'm hematologist, so we were seeing so many blood clots, like pulmonary embolism and stroke. So that's also needed to
Right.
bring to attention.
That's true.
So once they find symptoms, when should they go for testing, and what tests are available, and where can they get them?
Yeah. Can you go next slide, please? So there are 3 tests available right now in the worldwide. The most important is a molecular test called PCR, the preliminary chain reaction test. This is usually do by swab test. They use a swab from the nasal or oral. And the test, if test is positive, means there is obviously reactive infection going on. The second one is antigen test. It is a rapid antigen test, and it will tell us exactly, whether we have infection or not. But the sensitivity compared to PCR is less for antigen tests. The other one is called antibody, which is a serology test. You will blood. They draw the blood and test for antibody. The antibody is positive. That means patient get infected in the past infection. But only caveat here, this test won't tell us they have active infection or not. So that's the problem with the antibody testing. So the gold standard at this time is a molecular test called PCR, which is available in all the labs. Nowadays, doctor's offices also it will be done. This can be performed while you're waiting in the waiting room, or but it has sent to the lab for testing some of the scenarios. But these are the tests widely available right now, and obviously most of us have been go through this, because whenever you have a upper infection or sore throat, and we go for this because of the worry of the COVID infection. So these are available right now in the laboratory wise. Next slide, please. If you look at the infection severity, 80% of patients they presented with less severe infection. Usually they get better. About 14% of the patient they require hospitalization because of respiratory illness or diarrhea, or some people may come with liver tests are abnormal. That is not uncommon with COVID infection patients. There's nothing much to do, watch them, and they get better by itself. But you have to rule out patient have any other liver problems before you think that this particular liver illness is because of COVID infection. About 4% of patients required intensive care unit admissions. Those are the one sick people. They have to watch very careful. That in these are patients, the doctor Juvvadi mentioned, they can develop blood clots, and they can get pulmonary MLI, and they're really sick people. Okay? They need a real treatment. She's going to talk about that later. 1.5% catastrophe, they can die because of infection. So that is the severe infection has been nicely mentioned in this graph, in this slide. Next slide, please. Now we'll come to the treatment, and I think I would like to Dr. Juvvadi take over from here, and she's going to talk about the treatment, various kind of treatment available at this time, and vaccinations. What are the different type of vaccinations, and also she's going to talk about variants at this point of time globally. Please welcome Dr. Juvvadi.
Thank you, Dr. Jonnalagadda. That's a very excellent preview. And I think it's helpful for people to get tested, watch for symptoms. And now that we know the symptoms, we need to know how to treat it. 80% of them do not have symptoms, but they are tested positive. Either they're exposed to a person with COVID or they want to get it tested. Even if they don't have symptoms, they still shed virus and they are infected. So they need to be isolated at home, this social distance from other people because they can spread and those guys can get sick. Hand hygiene is strongly recommended and that should last for 20 seconds. We say be adequately hydrated, check your oxygen levels with a pulse oximeter, and if your pulse ox drops below 93%, please get to the hospital. And you can have low-grade symptoms like fever or cough. You can take Tylenol and cough suppressants. Next slide, please.
Dr. Juvvadi, question, somebody has no symptoms for like mild aches, anything, do they really need to take Tylenol or Advils?
No, they don't need to. Only if they feel sick with fever or any kind of pain. Next comes patients, like they're not very sick to be hospitalized, but they do have symptoms. They can have low-grade fever, they can have cough, fatigue, body aches. These are the patients where I want to emphasize there is treatment available with monoclonal antibodies. There are two products available right now. One is Eli Lilly's bamlanivimab, and the other one is Regeneron's product, Casirivimab and Imdevimab. So these words are complicated. Whom do we give this? Anybody who has COVID positive within first 7 to 10 days. These are the monoclonal antibodies which are given through your vein over 1 to 2 hours. There are multiple infusion centers in the hospital and freestanding centers are administering this. What we have seen is, these patients, when they got it, they recovered faster. They did not require hospitalization. So this is a major fraction of patients who need to be getting this treatment. Next one, please. And who are eligible? Anybody who is 65 years and older, 55 years old with hypertension, heart disease, lung problems, diabetes, kidney disease, or immunosuppressed. Any of these patients are eligible. You just need to tell your primary care physician. They write the orders and you can get to these centers and infusion is administered, very well tolerated, helps prevent hospitalization and helps recovery faster. Next one, please. When we deal with patients who are sick and who needs to be hospitalized, our goal of treatment is twofold. One is we want to halt the multiplication of this virus, the COVID virus, which is very notorious. So we use an antiviral drug called as remdesivir. This has been used previously for Ebola virus infection. This is given intravenously for 5 days, and this halts the viral multiplication. But more important, the second half of sickness is resulted by the immune response triggered by your body against this virus. So that inflammatory response is what causes damage to multiple organs like lung, liver, kidneys, your coagulation systems. And so it can affect any of the organs. Like when you look at the lungs are supposed to be like balloons. When you inhale, it's supposed to, inflate and make oxygenation possible. But patients with COVID-19 infection, instead of balloon, it becomes more like a rock. So it becomes impossible to oxygenate some of the patients. So the way we treat them is by giving oxygen with a nasal cannula, or some of them may get worse, may require a ventilator. That's the respiratory support. And we also give something like anti-inflammatories like steroids and IL-6, interleukin-6 inhibitors for patients who are very sick and not getting better. And the whole of the pathology in every organs, like patients who died of COVID, when the biopsies were done, there were small clots formed in the lungs, kidneys, and multiple organs. So we think there is something triggering the clotting mechanism in one's body, and blood thinners like Lovenox injections or pill like Eliquis has helped patients to at least combat this hypercoagulable state. Next one, please.
Dr. Juvvadi, I have a question for you.
Sure.
Nicely said about the treatment point of early, mild and moderate disease, you're going to give monoclonal antibody, okay? And severe diseases, you mentioned antiviral and inflammatory. So what are the, I know President Trump infected with the COVID-19. So what kind of treatment he received at the time?
He got a monoclonal antibody produced by Regeneron. That's one of the two available. So he got it. Typically, at that time, we were using what we could use, whatever we can grab. But in present scenario, normally monoclonal antibodies are indicated for non-hospitalized patients who have mild to moderate disease, who do not require hospitalization is the indication. We do not use those monoclonal antibodies for patients who are hospitalized. But Regeneron antibody is what he got.
Thank you.
The next one, please. So this is just to summarize. I mean, if they have superimposed bacterial or fungal infection, we support them with antibiotics. Respiratory support is the key thing. Their requirements may differ depending on the severity of the infection. They may need nasal cannula, mechanical ventilation. Steroids have been really helpful. Dexamethasone is an administered intravenously for 5 days, have resulted in decreasing the mortality. The death rates are less, especially when used in conjunction with remdesivir. And dexamethasone is not indicated in patients even if they are hospitalized, if they're not requiring oxygen. As I said, to combat and to halt the inflammatory response in the body, IL-6 inhibitors have been used, but they have specific criteria who needs these. And there was a lot of buzz around Plaquenil, and a lot of patients were getting Plaquenil, but there were a lot of cardiac side effects, and FDA has revoked use of Plaquenil maybe like August of last year. So we are not using Plaquenil now. The other thing what they were doing is people infected with COVID, so they mount an immune response. You mount antibody response to fight the infection. So they identified patients who recovered from this infection, and they took their plasma, their blood, and they got those antibodies and gave it to patients who got admitted to the hospital. Initially, we were doing it, but now it's fallen out of favor. Clinical trials are going on. So we are not routinely using it right now. So these are all the treatments available once you have the infection. Next slide, please. And what can we do to prevent? Prevention is where we have to focus. And again, continuing social distancing, as Dr. Jonnalagadda mentioned, we say at least distance about 6 feet. Wearing masks, several masks are available. You can use surgical masks, you can have N95 as physicians. And when we get exposed to sick patients, we use N95. That is very protective. And washing hands, as you see, the fomites. And when you touch doorknobs or you're sharing plates, spoons, you can transmit from one to other. So as long as you're washing 20 seconds with clean soap and water, thorough washing has helped self and others. And you have social responsibility of not spreading this virus. If you're sick, that's what we tell all our staff. If they're sick, please do not come. And apart from all these measures, we do have vaccinations, what can help to prevent this COVID infection. Next few minutes, I'll focus on that. Next slide, please. What are vaccines? I mean, these vaccines have been for last 100 years. First vaccine was smallpox by Edward Jenner. And what do vaccines do? They trigger immune response so that you are producing antibodies. And when you get infected with this organism later on, your body knows how to fight it. So this is not a new technique. It's been there for the last 100 years, smallpox, measles, tuberculosis, hepatitis. We have at least so many vaccines already what we use. And I want to focus, conventional vaccines always used inactivated or weakened virus. But now with COVID-19, I'm going to focus more on the new technology of mRNA. And it's amazing how soon we got this COVID vaccine available for all of us. Conventional vaccines take 5 to 8 years for the testing and be available for the community. As Dr. Jonnalagadda mentioned, 120 million people are affected globally. So whole world came together during this COVID pandemic, and everybody identified this as an emergency, and all of the organizations put their resources, their resources and knowledge, and all of them worked to put this vaccine together. And China gave us the sequence in Jan 2020, and we started producing these vaccines. There are about 96 vaccines available, 266 clinical trials, which is amazing, and 12 approved vaccines worldwide, but we have 3 vaccines available in United States right now. And I think it was available within last 6 to 8 months of development. Next one, please. And we have 3 vaccines available, Mrna, Pfizer, and J&J vaccine. And who can get it in Texas? First vaccine was approved December 14th, 2020, and it was open to class 1A, which are frontline health workers and residents at long-term care facilities. Once these guys were vaccinated and in process, 1B was open, which was 65 years or older or 55 years old with any kind of comorbid conditions like cancer, kidney disease, COPD, who have lung problems, heart conditions, obesity with BMI greater than 30, diabetes. All these patients have increased predisposition to COVID and can get very sick because they're at high risk for severe infection. Class 1C, I mean, from March 10th, Texas opened for ages 50 to 64 years old, teachers and licensed childcare workers. All these guys are able to get it. You just have to register with your community, I mean, with your county, and also a lot of hospitals are giving it, like county hospitals, Parkland, UT Southwestern. We recommend you go and register on your county website and you get intimation. So far, 8 million doses have been administered in Texas. Some more, like both of the vaccines, like Mrna and Pfizer, need 2 vaccines. So only 10% of whole Texas has been fully vaccinated. So 109 million doses were released for total of United States, and 20% of total US has been vaccinated. So long way to go right now. Next one, please. So this is a busy slide. I mean, this is just information for anybody who's interested in more details. This is the way how they were doing it before, like live attenuated, like they take the virus or bacteria, whatever causes the infection, they either kill it or just weaken it, and they inject into patients where it stimulates response. But these were grown in like eggs, they take long time to produce. but they have robust immune response, and that's been the traditional vaccines. But they're slow to produce, and it takes long time. So newer technologies like mRNA and viral vectors have come into place. Next one, please. I just want to focus on what vaccines are available and what is the schedule and what are the side effects. First vaccine was Pfizer vaccine, which was approved December 14th, 2020. It's an mRNA vaccine. It's a single-stranded mRNA vaccine. And the problem with mRNA vaccines are they're very unstable. So you need to have a lipid coating. And also it has to be stored in very cold temperatures. So transportation was a problem. And this was tested in 36,000 patients who were 16 years or older. You need 2 doses. They're intramuscular injections. You need to give them 3 weeks apart. A week after the administration of the first dose, you start producing, actually almost about 2 weeks, you start producing antibodies. But 52% immunity has been established after first dose. After second dose, which is 3 weeks later, you get first dose, and 3 weeks later you get second dose. After your second dose, 2 weeks later, you're immune by 95%. So that's actually excellent. And it's been covering the variants, which I'm going to mention again, like UK and Brazil, and it's very effective and well tolerated. The second vaccine is Mrna Vaccine. Again, that's also mRNA vaccine. Here, it's approved for patients, or it's approved for 18 years or older, and 2 doses are needed, and they are given 4 weeks apart. It's intramuscular injection. After first dose, it's effective in 74% of patients, and efficacy of 94% established after 2 weeks. And it's covering both UK and Brazilian variants. And this was tested in 26,000 patients, or patients who got administered. And the third, actually, Mrna was also approved in December 18th. And J&J vaccine was approved February 27th. Again, it is a viral vector DNA vaccine. It has easier storage requirements, again, given 18 years or older. It just needs 1 dose, and the efficacy is 66%. But, that was bothering a lot of people. They said others are 94 and this is 66. But when you look at the data, it decreased the hospitalization greater than 80%, and it has good coverage with South African variant too. And it's tested in 44,000 people. So right now, these 3 vaccines are available. Some of them are able to get Pfizer, Mrna, J&J. We are recommending whatever is available, one should get it at this point.
So, Dr. Jonnalagadda, question. Which vaccine is better than other?
Right now, when you compare, we don't have a randomized study. Like when I say randomized, we are not giving, we are not comparing 100 people giving Mrna or 100 people, you're not comparing each, one vaccine to the other. We do not have any kind of randomized studies yet. These are independent studies. So right now, with this data, we cannot say what vaccine compared to the others. So all of them have proven to be effective. So whatever is available, we should get it.
So how about, in general, the pregnant woman, for example, people get pregnant, can they take vaccine?
Yes. Again, we do not have data, again, in pregnant women, but there are some studies which are saying it can cause premature COVID infection. If a pregnant woman gets, they can have premature deliveries and all. But again, data is not clear, but there's no contraindication to get vaccine in pregnant women. They should get it.
Yeah. How about if somebody got infected in the past with COVID-19? Can they take vaccine?
That's a good question. Say you have COVID infection, your body is mounting response and you produce antibodies. But right now, CDC guidelines were 90 days after your COVID infection. But recent amendment was if you have recovered from symptoms, if the acute phase is over with, you can get COVID vaccine.
So for example, if somebody took vaccine Mrna, for example, do they need to take a booster Mrna or they can go to Pfizer?
Right now, we recommend to take the same one because that's how it has been tested. So what we are telling is, I mean, in 3 weeks, say you get Pfizer and 3 weeks later, Pfizer is not available. So they get very antsy and say, let me get Moderna. But we say you can delay up to 42 days. So you can wait. There's no harm in delaying a couple of weeks, like 6 weeks from the first one. And we, unless and until it's not available, recommendation is to stick to the same original one.
Good.
So better to get the same vaccine. Even though the technology is the same, the ingredient, the formulation is different. And the technique here is your body is learning to produce that protein and identifying, and your body has plasma cells and memory T and B cells, which are recognizing that. So the efficacy can be reduced if you use two different ones. So next slide, please. Lot of people are scared, hey, if I take vaccine, what's going to happen? To be honest, we were one of the first ones. It was released on December 14th and I took it on December 15th. So it was not bad at all. Lot of times, the common thing is low-grade fever, headaches, you can feel fatigued, muscle aches, and a lot of swelling and redness at the injection site was seen. And I'm an oncologist. Another thing what we are seeing is when you get on that arm, we are seeing lymph nodes in the armpits being swollen. So we do patients mammograms and then, we are seeing lymph nodes there. So we say don't take a mammogram for 6 weeks after your vaccination. So actually it's very well tolerated except these mild symptoms like immune response, whatever it is, fever and some pain. But some of them, there are few cases where they developed anaphylactic reaction. By name anaphylaxis is you have closure of your throat and severe infection. So we recommend not to get another second shot if you had anything like that. And that's the reason people are being monitored for 15 to 30 minutes to see if you have any reactions. Apart from anaphylactic reaction, which can happen immediately, we also notice some reactions within first 4 hours where people develop like hives, rashes, like bumps or wheezing. This is called immediate hypersensitivity reaction. We do not recommend them to get a second dose when you have these two. And also recommendation is to consult an allergist. Next one, please. And again, this virus is notorious. As Dr. Jonnalagadda mentioned, and that picture shows the classic hallmark of this COVID-19 virus is that spike protein. That's how it enters person's cells, get infected. And that is the key thing where they have identified the protein sequence even for these vaccines. And secondly, the change in that protein configuration makes it mutated and you have seen various variants. So the change in the spike protein is what led to 5 variants, what we are seeing now. And why is it important? Why do we need or concern? What is the concern about these new variants? Or we think probably these are spread easily, fast, and they may make patients sicker. And the testing, what we are doing right now may get false negative because they may not pick up these variants. And other question is what vaccines we have right now, are they effective against new variants is a problem. And again, what do we do for this? All Pfizer, Moderna, J&J, they got the sequence of all these variants and they're trying to incorporate that and get new vaccines with boosters so that these variants are attacked. Any questions, Dr. Jonnalagadda? You can ask me.
Sure. So the variants, at this point of time, what is your recommendation? So somebody, had a vaccine, and you think can I go ahead without a mask, or I still need to wear a mask?
No, as we said, I mean, there are actually that's a very good point you brought up. One is we are vaccinated. Even if you're vaccinated, first thing is you can still carry COVID. You can still be a carrier. So if you're meeting a person who is not fully vaccinated, you can transmit that COVID virus to that person. If one is vaccinated, see, I'm completely vaccinated. If I'm exposed to COVID virus, what happens is I still get infected, but that infection is subclinical. I mean, I'm not going to get sick. I'm going to get mild infection because my antibodies are going to act against that. But same thing, but you can be a carrier, you can spread to other persons. So we still recommend you need to wear a mask even if you're fully vaccinated. Unless and until you're going and meeting a person who is also fully vaccinated, then you can avoid. But again, you brought another point of variants. What vaccines we took is not completely protective against all the variants, and still you can carry it. So my answer is yes, you wear mask.
Good.
Next one, please. Next slide. So this is a lot of buzz is going on. So, we just wanted to look what are the available ones. That B117 is the UK variant. That's the most prevalent form. It's spread easily, but it's not, it's severe and it spreads easily. But luckily Moderna and Pfizer and J&J covers it. B1.351 is a South African variant, which is the concerning one because the existing vaccines are not very protective. Of all the three available, J&J has better coverage for that. Brazil variant, again, it's more contagious. It's not deadlier. It's covered by Pfizer. And the other two variants locally found in United States is California variant and New York variant. Luckily, I mean, we do not have much data, but looks like these vaccines are protecting that. Next one, please. So this is just a summary, like, are these variants being protected by the existing vaccines? Pfizer is good with UK, but South African thing, there was, when you looked at the antibody titers, there was reduction of 65%. Moderna, the same thing. J&J also reduced, but better than these two. Again, AstraZeneca and Sinovac, again, they also reduced antibody levels. So we need more. I mean, they're all thinking of getting booster shots maybe 6 months after completion, and they were planning to incorporate new variants there. Next one, please. So this is a common question, like, is mRNA technology new? And there are a lot of myths going on. It's going to change my genetic makeup. So a lot of my patients themselves ask me all the time. I just want to clear, this is not a new technology. It's been there for a long time. We have used for Zika and Ebola viruses, and we have used this technology in cancer treatments. What clear thing here is, to handle the COVID pandemic, you need something which is effective immediately. We can't wait 5 years for a vaccine like this virus inactivated vaccine. So what they did is they sequenced, actually, it's interesting to know the history, how this was developed. In China, they sequenced the COVID virus vaccines from a person, like who from a swab, they identified the virus, they grew and they analyzed the sequence and came up with this mRNA sequence, which is nothing but like a code. It is the genetic code, what your body is telling what protein to make. It comes like AUCTTT, that is really coding for the spike protein. So that's what was identified, the genetic sequence. And once they got the sequence in the lab, they just produced millions and millions and millions of copies. That's the reason why we got so many million doses worldwide in such a short period of time. So there's no virus in this, so there's no infection. It's not going to the nucleus of a person's cell, so it's not altering your genetic makeup. So there's no infection, it's fast, it's not changing anything. It's just telling your body some instructions to say, produce this spike protein. When you produce that, your body is identifying that as a foreign thing, producing antibodies to protect you. And this has been produced in large quantities, short period of time. It's safe. Only thing is there are some drawbacks of transportation and storage. Next one, please. This is the simple form, where you're giving vaccine with mRNA. So it enters, this is what is getting into your cell after the injection. So this strand is mRNA, it enters your cell and it's telling your cytoplasm to produce this protein. Once you see this protein, your body's pull is like lymphocytes and memory plasma cells, they produce antibodies and they attack it. So that is the simple explanation. Next one, please. This is how a J&J, I don't want to complicate it. That's a DNA vaccine. DNA cannot be transported by itself. You need to get into adenovirus incorporation. So this virus, adenovirus, is just going to act as a vector in the sense it's just transporting this DNA sequence in the vaccine. Once it enters the cell, this adenovirus is gone and it forms the protein. It gives instruction to the proteins and identified as foreign objects, and your body produces antibodies. With this, I would like to end and can be open for questions.
Thank you so much, Dr. Sridevi. That was great. I actually have the Q&A session is going to go ahead and start. I have a question from Mr. Brian Jarvis. This is a good one. The current vaccines have emergency use authorization status. Many people say that this means that vaccines are not FDA approved. Is this true? And if so, what additional work must be done for these vaccines to have approved status?
That's a great question. And FDA is a very tight-knit situation. It's a tight-knit one for the safety of any kind of drugs or vaccines. Emergency use authorization is approved by FDA the times of emergencies, like COVID. So, but it doesn't mean it's not safe. They have gone through preclinical testing. There were all these vaccines have gone through safety trials. They have seen what's the dose and what's the side effects. They have seen everything. So it is still safe. Emergency use authorization is the preliminary one. Next goes for complete licensing, which will be done shortly.
Right. And, when you and I were talking earlier, you mentioned that this was a concerted effort globally to find. So the speed in which things, the speed in which we were able to find a vaccine is not indicative of a poor quality vaccine. If you could talk to that a little bit.
No, actually, these vaccines has been tested 3 trials: phase 1, phase 2, phase 3. Mm-hmm. In phase 3, all that has been investigated by probably 30 to 40,000 volunteers involved in this study. Okay, so they've been tested very well, thoroughly about safety, efficacy. I think it's good.
Thank you, sir. And we have another question from Gloria. What are the concerns raised about the levels of intact mRNA in Pfizer vaccine? And what is the percentage of intact mRNA molecules?
What do you, Gloria herself is an immuno-oncologist, so she should tell me. But
that was a complicated question. Well, we can move on to another one. I think a big question here is how long is the efficacy, how long does the vaccine stay in our body? And do we need to get the vaccine every year?
So that's a very good question. We are still trying to follow. I mean, we don't know the answer yet. So we think it could be effective for 6 months to a year. So we're going to monitor. I mean, I think studies are going to be done monitoring the titers of the antibodies, what's the nadir, what's the drop. So as you mentioned, we certainly looks like the way we are going is we'll need another booster with new variants. Whether this is going to be like an ongoing, like flu is what people are anticipating.
Okay.
Every year you may have to get it.
We don't know. They may mix a flu vaccine with the COVID vaccine in the future, one shot.
Correct.
Yeah, right now there are about 96 vaccinations under trial now. So we don't know, we may get one. Wow. Right now, take whatever you get it.
Right.
Absolutely. And, there are groups of people that are hesitant to take it. And for fear of some of the things that you had, already discussed in relation to the fear of the mRNA vaccine changes your DNA. And with much certainty, I mean, I know, can you just reiterate what you just said about that earlier? Either one of you, please.
Yeah, exactly. Like, I can tell you myself, when I took it, my patient said, Dr. Juvvadi, if you don't have 4 heads in a month, I'm going to do it. So there is a misconception that it's changing the DNA. I just want to say it's not going to your nucleus or integrating or changing any kind of genetic material of what you have. It's just giving your cell an instruction to produce this COVID protein. So you're using your own body to protect against it by getting antibodies. So it is safe. It's not going to change your genetic makeup. And again, the myth of it's not being tested adequately is also not true. Everybody's attention was on that. So it got prime attention. That's it.
Gotcha. And Gloria, did you want to ask any other questions? Everybody, this is Gloria Mather. She's one of our board members at ACT. So, and she is a doctor herself. So if you want to go ahead and speak and ask, Gloria, by all means, do so. Chime in. You're on mute, Gloria. Well, one of the questions that Gloria had, there she is. Oops, back on mute.
I sent it to you already, so I don't know what
okay.
I had typed
I will ask on your behalf, no problem. So what are the long-term effects of the vaccines? Are there any?
We do not know at this point, but some predictions are, do you end up having some autoimmune problems? We do not know.
It's just too soon to tell at this point.
Yeah, we don't have enough follow-up yet, but they are predicting some autoimmune things could be in the light.
It could be. Okay.
That's why people are literally like a little bit reluctant for young kids because we don't have much data there. I mean, anything growth failures and all that. But some trials are underway for them, age 12 to 15.
And I have one last question before we close. The UK is currently giving everyone in their country the first dose of the vaccine without reserving the second dose. And this is with the intention of, giving more immunity to a larger or broader scope of people versus, having fewer people be fully vaccinated. What are your thoughts on that?
Yeah, I agree totally. As you mentioned, like with one dose, depending on the vaccine, the immunity could be anywhere between 50 to 70%. So at least, if you can double the people instead of giving it to 10 millions, if you can give it to 20 millions, one thing is you're at least giving everybody immunity. So even if they're infected, they get subclinical infection. And secondly, you're also helping for herd immunity. The transmission in between people is lesser. So it is two-way fold, and that is until you get more and more availability. That's I think a great idea. And UK is the place where they said you can have 12 weeks interval. I mean, 3 months can be between 2 doses.
Right. Dr. Sudhakar, any last remarks?
Yeah, I think, we are, I think, this is the mRNA technology, a greater technology for rapid invention of the vaccine compared to previous vaccinations. I think hopefully we can able to break this infection soon by vaccinating most of the Americans. And again, thank you very much inviting us today. Thank you.
Thank you both for joining us and collaborating with us on this. This is such important information. And once again, science does not lie. So we always want to be fact-based and stand behind, the research of doctors and scientists such as yourself. So thank you so much for presenting today. We're so grateful for you. But on that note, that brings our event to a close. But before we go, I just want to take a couple of minutes or just a couple of seconds actually, just to touch on a couple of things, or just one particular thing. This is just, regarding the horrific murder of 8 people in Atlanta. Everyone's heard about this, the shooting of 8 people in the massage parlors in the greater Atlanta, Georgia area. And this has created quite a just sick feeling amongst the Asian Pacific AAPI community in general. Discrimination and crimes against the AAPI community across America is on the rise. And it is up to each one of us, regardless of our race, to stand against this. In the upcoming days and weeks, you will see our chamber, as well as other organizations here in the North Texas region, and as well as nationally, present different types of events and campaigns against this type of hate. So I hope that you will engage with us in the future as we put these events on, and I hope you will stand with us as we stand against this together. And on that note, I'm going to just one last thing. Divya has put in the chat box links to where you can actually register for the vaccine if you have not registered already. So there's all kinds of, there's many different locations, and we will also put the link for Stop AAPI Hate. And this is a place that you can actually report. And reporting is essential when it comes to hate crimes, or any kind of crime for that matter. But this is a forum, and an online forum that you can actually submit and report. But that said, I'm going to go ahead and close this event. Thank you both. We are so truly honored and grateful to both of you for joining us today. And have a good afternoon. And thank you all for joining in today. Take care.
Thank you.
Thank you.